Next speaker is Dr. Berg about facet joint arthritis.
Thank you for letting me present here. So, first of all, I'd just like to, according to the surgical complications, beware of that. Very rare patients have a late scarring of their ureters. If you have a patient with hydronephrosis, you have to check them up. I had like 3 cases of that due to scarring after the surgery. Not a primary injury to the ureter, but some scarring coming a couple of months later. But that was the only addition in intraoperative complications. The disadvantages of total disc replacement is that it doesn't provide, as a healthy disc, a counterforce to movement. The patient has to add that with their musculature, because the mechanical disc is absolutely loose, as is not a healthy disc. After years of low back pain, they have a very, very strong rectus abdominis muscles, rectus erector spine muscles, and weak rectus abdominis muscles. They are, you see them, they are very contracted in their spine muscles. That means that they already from starters, prior to surgery, give a lordotic force on their lower back. When nothing is restricting mobility, patients might tilt over in segmental hyperlordosis after surgery. This also happens if we put a too high implant in, because then we give them that angle from starters. And if we don't put the prosthesis all the way to the PLL, we also alter the angulation with a mechanical disc that has a defined center of mobility. And all these things would lead to an increased risk of facet joint arthritis down the road. And we tried different ways to prevent this from happening. We got the producers to make us low enough implants, and we see to that we put them all the way to the PLL and exactly midline, so we don't give uneven forces on the facet joints. And for the last 10 years, we have developed a program that all my patients go through for a couple of months prior to surgery, where they lengthen their back muscles and shorten their rectus abdominis to give them a possibility to have this balance when they get fully mobile again. This has improved things, and facet joint problems has decreased. We saw them to quite a higher extent than the previous presenter. That was actually the only complication that we had, was late facet joint arthritis, so we tried to approach that. If you look at this picture, and I made an A-lift because facet joint arthritis in the lowest level, and I put a disc in the upper, and you can see the tilting. The A-lift cage was 15 degrees, and you can see that the patient hyperlordotic angle of the disc processes segment. That would create a possibility of facet joint arthritis if you don't address it immediately and get them to prolong their lumbar muscles and shorten their abdominal muscles to get away from this hyperlordosis. And you got a time frame before the arthrosis is definite. It takes some time to develop an injured facet joint, so you have some time to do it if you're just aware of it. This is another patient that went through several years of intensive physiotherapy, and eventually came to my place because of 3-segment degenerative disc disease. I didn't fully know that they were all painful, but I did this provocative discography that I sometimes do when I'm in severe doubt, and it was absolutely positive for all 3 of them, and we can discuss the value of discography another time. I did that anyhow, and then I put her into surgery, and I made an ALIF. No, I put 3 discs in, and the upper one, after a while, started to tilt over. She was developing facet joint arthritis in the upper segment. I tested her with facet joint blocks in all 3 segments, but the only one that released the pain was in the upper segment. So eventually, the only way to cure this was to fuse that segment. And then I fuse it in some lordosis, because that takes off the pressure of the other segments to go into lordosis. So this program that we do prior to surgery, I think it's that has really been a course changer for us in our results. When we do this, as you can see here, the patients are well prepared. They know from starters that it's their responsibility to take care of this, so they won't develop a segmental hyperlordosis. And of course, they have to be strong in their straight abdominal muscles. And this gives them the ability to balance their spine when they again get mobile as a teenager. If you look at this, this patient develops a much more pronounced lordosis in 4-5 than L5-S1. And this is not physiological, but that is an effect of very short posterior structures. This is how I'd like it to look after surgery. That means that they go back to a normal curve of the spine. They are not in one segment more lordotic than another. And this is what I'd say would be a physiological lumbosacral angle of this person. When we have multi-segment cases, one segment, as previous speaker said, might be too hyperlordotic to use a prosthesis, or already having facet joint arthritis. Then you should consider an ALIF on that segment, and you should have ALIF implants with both 15 and at least 20 degrees of angulation, so you can pick up most of the lordotic angle there. That means that they don't have to go into lordosis in the mobile segment where you put a disc. And then you can see what happens if you place the implants off midline direction. I mean, you can see the preoperative picture where the lady was tilting over. I put a disc that I put a little too far to the left, but it looked nice right after surgery. But then when she came back a year later, she went back to her tilt, exactly as you just heard from the other speaker. And that means that she has, at that time she was still doing fine, but I know that she has a high risk of facet joint arthritis at the right side because of this tilting. Then we had the other problems, much less frequent, but even so very serious. I used a lot of different prostheses through my 23 years with discs. I used these 2 metal ones, Maverick and Kineflex. And I started to see that some patients developed a strange type of spinal stenosis, and preferably multi-segment cases. In all, I had 4 cases. 3 of them were multi-segment, and 1 was a single segment case. This stenosis is difficult to address because it's like glue. The thing that did with them was posterolateral fusion to take away mobility, so no more nanoparticles would be produced from the prosthesis, since they were obviously sensitive to them. And then I did a thorough decompression, but I left the prosthesis in place. I've actually never shifted out the prosthesis, hadn't had to so far. This is an example of this. Patient was doing very fine. She was a nurse, coming back to work immediately. This was October 12. Then I saw her in March 13. She came back from skiing vacation and was absolutely symptom-free and very pleased. It looked nice, in my opinion. And then just a month later, she started to experience weakness in her legs. But she was very physical active. She thought maybe I've trained too much or whatever. But then in May, this weakness increased and pain was added, and the weakness was progressive. This was 7 months after surgery. And then she went to the emergency department of the hospital where she worked and was hospitalized in the neurologic clinical for further examinations. And MRI wasn't saying too much. Since we have these metal processes, it's hard to judge what's going on there. I could see that she had quite some segmental hyperlordosis, as you can see. And I don't know if you can see it, but on the right picture you can see the contrast from the myelography. It's this thin here, just so something is filling out this area. And that is not what they call pseudotumors in hips, but it's the same type of reaction. When CT was added, you can see even clearer that the contrast has difficulties to pass this area where the prosthesis is. And I did this decompression, and that is a difficult decompression, I tell you, because it's like glue and it sticks to the dura. And anyhow, I got the nerves free, but she's already had them under severe compression for a month. This is what it looked like. I gave her a lot of lordosis in the fusion, since that was the way she wanted to go. And then she started to restitute. And slowly, step by step, was better and better. But even now, a couple of years later, she doesn't have exactly the full strength as she remembers having. I mean, she's physically active again and this and that, but actually she has some, but minor sequelae from this. In total, I had 4 cases, 3 multi-segment, and time-wise, I thought that the producers had changed something in the materials, because I used them for several years before, and then suddenly I had, within half a year, I had 4 cases, but the producer said they didn't change anything. But I immediately stopped using metal-on-metal processes when I had these cases. And since I've done a lot of cases that I follow in different studies and this and that, I have had no late cases. I mean, obviously, if it develops, it's about 7 to 9 months down the road. If it hasn't developed at 1 year, I haven't ever seen it. So all these patients out there, they obviously are not sensitive to these nanoparticles, but some, very few, are, and they have a reaction. Thank you.
Thank you, Svante, for this very interesting lecture. We will discuss later on. Some questions occur, obviously,